Hello everyone, welcome to a module in the renal system. In this module, we will talk about urinary tract infections. Okay, so let us start with the first topic, that is the urinary incontinence. Now, there are three basic types of urinary incontinence, which include stress incontinence, urgency incontinence, and overflow incontinence. We look at each of them individually, starting with stress incontinence. Now, stress incontinence majorly occurs due to outlet incompetence. So, let me just explain you what is incontinence. Incontinence means leakage of urine, means leakage of the urine. Now, why does leakage of urine takes place? It can be due to outlet incompetence, that means the urethral hypermobility or intrinsic muscle deficiency. Is it clear? So, when the intrinsic muscle or the intrinsic sphincter is deficient or there is hypermobility of the urethra, it can lead to stress incontinence. Now, in stress incontinence, there is leakage of the urine with increase in the intra-abdominal pressure. That means whenever a person sneezes or lifts or coughs, there is increase in the intra-abdominal pressure, which leads to leakage of the urine. Am I clear? Now, in stress incontinence, there is a positive bladder stress test. That means if a person is asked to cough or do Valsalva maneuver, then there is a leakage observed from the urethra. Now, what are the primary associations of stress incontinence? It is obesity, vaginal delivery, and prostate surgery. Am I clear? So, these are the three major associations of stress incontinence. And the treatment is, since the stress incontinence occurs due to excessive intra-abdominal pressure, the treatment is majorly strengthening of the pelvic floor muscles by Kegel's exercise. Okay, it can be also by weight loss or pessarius. Now, weight loss is due to obesity. Okay, since obesity is one of the major associations of stress incontinence, weight loss serves as a treatment. Now, let us talk about the second incontinence, that is urgency incontinence. It occurs due to detrusor muscle overactivity. It occurs due to detrusor muscle overactivity, which leads to leakage of the urine with the urge to void immediately. Am I clear? So, this occurs because of excessive activity or hyperactivity of the detrusor muscle, which makes a person to void immediately. Am I clear? Now, it is majorly associated with multiple urinary tract infections like cystitis, pyelonephritis, etc. The major treatment of urgency incontinence is again Kegel's exercise and bladder training. Okay, so what is bladder training? It's basically training your bladder to timely void or get distracted or relax techniques. The multiple treatments using antibiotics includes antimuscarinics, that is oxybutynin. Mirabegron is also used to treat urgency incontinence. Am I clear? So we have spoke about stress incontinence and urgency incontinence. I'd like to add that if a person is presented with symptoms of both stress incontinence and urgency incontinence, it can lead to mixed incontinence, which has features of both stress and urgency incontinence. Am I clear? Now let us talk about the last one, that is the overflow incontinence. Now, overflow incontinence occurs because of excessive emptying or incomplete emptying of the urinary bladder. Not excessive, rather it is incomplete emptying. Excessive activity of detrusor muscle leads to urgency incontinence, whereas underactivity or low activity of detrusor muscle can lead to overflow incontinence. Am I clear? Now, it can occur with increase in the post-void residual on catheterization or ultrasound as well. Now, it can also occur due to outlet obstruction, example benign prostatic hyperplasia. The major associations include polyuria, which is associated with diabetes, and bladder outlet obstruction, which occurs due to benign prostatic hyperplasia. Okay. Now, the third cause, which is often presented in the exam, is neurogenic bladder, which is presented as multiple sclerosis. Okay, so if a patient is presented with multiple sclerosis, it eventually indicates overflow incontinence. Am I clear? The major treatments include catheterization or frequent catheterization whenever required and relieving the obstruction by using alpha blockers. Am I clear? Now let us go to the urinary tract infection. The first one is acute cystitis. Now, acute cystitis is basically the inflammation of the urinary bladder, which is presented as suprapubic pain, dysuria, urinary frequency, and urgency. I again repeat, it is presented with suprapubic pain, dysuria, urinary frequency, and urgency. Now, the systemic signs like high fever or chills are usually absent, and acute cystitis is majorly associated with female sex. Now, why is it so? Females have a shorter urethra, and hence the bacterial infections such as of E. coli, which is the most common cause, or Staphylococcus saprophyticus, which is seen in sexually active women, or Klebsiella or Proteus mirabilis can rise up easily if there is a short urethra. The other risk factors include sexual intercourse, indwelling catheters, diabetes mellitus, and impaired bladder emptying. But I'll again say that major risk factor is female sex, sexual intercourse, and indwelling catheters. Okay. As I told you, these are the various bacteria that infect the urinary bladder causing acute cystitis. And just talking about Proteus mirabilis, it produces the ammonia scent in the urine. So if a urine presented with ammonia scent and symptoms of acute cystitis, then it is due to Proteus mirabilis. Is it clear? Now, the lab findings in Proteus mirabilis include positive leukocyte esterase and positive nitrites that indicates the gram-negative organisms. And if there is a presence of sterile pyuria, that means pyuria with negative urine culture. Okay, so there is negative urine culture of bacteria, but still there is pyuria. It can suggest urethritis due to Neisseria gonorrhoeae or Chlamydia trachomatis. Is it clear? So it can be due to Neisseria gonorrhoeae or Chlamydia. Now, the basic treatment is antibiotics like nitrofurantoin or TMP-SMX. Is it clear? Now let us talk about this next one, that is pyelonephritis. Pyelonephritis is distinguished into two parts, that is acute pyelonephritis and chronic pyelonephritis. Acute pyelonephritis is associated with neutrophilic infiltration in the renal interstitium. This is one of the most important and distinguishing features of pyelonephritis. So there is neutrophil infiltration in the renal interstitium, as you can look in this histopath. Okay, there is neutrophil infiltration in the renal interstitium. Now, pyelonephritis, due to the effect, it affects majorly the cortex with renal sparing of the glomeruli or vessels. Am I clear? Now, it is presented with fever, flank pain, that is costovertebral angle tenderness, nausea, vomiting, and chills. Now, it majorly is occurred due to ascending urinary tract infection caused because of E. coli. Okay, so E. coli is one of the most important cause of again pyelonephritis, just like acute cystitis. Now, the hematogenous spread to the kidney leads to excessive pain and fever. Am I clear? Now, in acute pyelonephritis, there is presence of WBC in the urine. This is the distinguishing feature. There is presence of WBC in the urine with or without WBC casts. Okay, and the CT scan would show striated parenchymal enhancement, as I have pointed over here. This is a striated parenchymal enhancement in the CT scan. Now, the risk factors include indwelling urinary catheters, urinary tract obstruction, vesicoureteral reflux, diabetes mellitus, and pregnancy. Am I clear? So it is urinary catheters, urinary tract infection, vesicoureteral reflux, and diabetes mellitus. Pregnancy is often associated with acute pyelonephritis. The major complications include chronic pyelonephritis, renal papillary necrosis, and perinephric abscess or urosepsis. Now, since it is again caused because of a bacterial infection, the major treatment include antibiotics. Now, when acute pyelonephritis occurs multiple times and there is a recurrent episode which is untreated, it can lead to something called as chronic pyelonephritis. So, let us talk more about chronic pyelonephritis, which is the last segment of urinary tract infection. So, chronic pyelonephritis is a result of recurrent or inadequately treated episodes of acute pyelonephritis. Am I clear? Now, it typically requires a predisposition to the infection such as a vesicoureteral reflux or chronically obstructing kidney stones. Clear? Now, there is a coarse, asymmetric corticomedullary scarring seen, often in cases of chronic pyelonephritis, and there's also blunted callisis. Now, the tubules contain eosinophilic cast resembling thyroid tissue. That means when you look at the histopath, you see these kind of tissue, which is often seen in thyroid gland histology, and hence it is called as thyroidization of kidney. Am I clear? Now, there is a rare form of acute chronic pyelonephritis, that is xanthogranulomatous pyelonephritis, which presents like a orange nodule mimicking a tumor. Okay, so it is a case of pyelonephritis which often mimics like a tumor and is characterized by widespread kidney damage. Now, due to the presence of granulomatous tissue which contains foamy macrophages, there can be widespread kidney damage. And xanthogranulomatous pyelonephritis is associated with proteus infection. Is it clear? So this is all about urinary tract infection. Thank you for watching this video. If you enjoyed the video, please click on the like button and do subscribe to this channel. Let me know in the comment section below which topics do you want me to explain. Thank you.